In the last two modules, we've talked about the scientific and statistical issues that guide Phase 1 research, and we've illustrated the ideas with a Phase 1 clinical trial of the treatment of metastatic melanoma. Now we're going to turn to a discussion of the ethical issues that arise in Phase 1 research. And for that discussion, I've invited my colleague, Dr. Robert Truog, who's a professor of medical ethics, pediatrics, and anesthesiology at Children's Hospital, to join us. Bob, we've been talking about Phase 1 trials, but I think they raise some unique ethical issues. Can you help us understand those?
Well, thank you, Jim. They sure do. Phase 1 research does have a lot of controversial aspects. So let's explore those a little bit. First of all, it's important that we differentiate between two very different types of Phase 1 research. There's Phase 1 trials that involve healthy volunteers, and then there are those that involve patients with serious or life-threatening conditions. And the ethical issues are different. So, for example, with healthy volunteers, they're typically paid for their participation in the research, and it's very important, since they're healthy volunteers, that we minimize the risk of serious harm. And certainly there are ethical issues there. How much is it okay to pay them? What kind of risks are acceptable? But that's very different from the kind of Phase 1 research that involves the second category, patients with serious or life-threatening conditions. Under these circumstances, typically no payment is being offered, and moderate risks are very typical of this kind of research, and even serious risks may be acceptable. Now, we're not going to be talking more about Phase 1 research with healthy volunteers. We're going to be concentrating on that second category, which includes patients such as those who were enrolled in this with metastatic melanoma. And here, the major ethical issue has to do with the fact that this type of Phase 1 research has a very low chance of benefit. Why is that? There's three main reasons. First of all, we know that 90% of the time, Phase 1 drugs never progress to Phase 2. So this means that 90% of the time, we find out that the drug actually doesn't work. Secondly, Phase 1 trials often recruit patients with any malignancy, not just those who are likely to benefit. So think back to the malignant melanoma trial. Now, based on the biology of the drug, we would expect it to work only in patients who have malignant melanoma and who have a specific mutation. But in this trial, for the Phase 1 part, they enrolled patients who had any type of tumor. Now, from a scientific perspective, this makes sense. The purpose of Phase 1 research is primarily to look at the toxicity of the drug. And to explore toxicity, you don't need patients with the disease under study. You can do this study in patients who have any type of a tumor or indeed no disease at all. So it makes sense from that point of view, but obviously from what we understand about the drug, the only patients enrolled in this trial who stand really any chance of benefit would be those with malignant melanoma and this specific mutation. Third is the problem of subtherapeutic dosing. So as we've learned earlier, a common strategy in doing Phase 1 research is that we start with very, very low doses of the drug that we don't expect to have any effect at all, and we slowly work up until we start to see some dose-related toxicities, and then we decide on what is a safe dose. Now, we know from doing these kinds of studies over a long period of time that typically if you are going to see benefit, it's only going to happen as you approach the maximally tolerated dose. So if we look, for example, at the malignant melanoma study, we see here that they started with very low doses, and here's the number of patients who were enrolled at each dose. And then they looked at dose-limiting side effects. And they gradually worked up on the dose, and then when they got up here to 1,120 milligrams, they saw 4 dose-limiting side effects, dropped back to 960, where they didn't see any toxicity, and so the dose chosen for the Phase 2 trial was 960 milligrams. But the point I want to make here is that if you look at all 61 of these patients who were enrolled in the trial, only these 12 received a dose that we would have expected perhaps, to be beneficial to them. And so the point here, for these three reasons, is that phase 1 trials typically offer a very low chance of benefit. And in fact, if you look at these studies overall, the chance of seeing any response is only about 5%. Furthermore, if you look at complete responses, the chance is even smaller, down around 0.5%. And in fact, the risk of having a fatal complication is about the same. So your chance of having a complete response in one of these phase 1 studies is about the same as your chance of having a fatal complication.
So Bob, that's very interesting, but given what you've told us, I'm having a hard time understanding how an investigator can ethically enroll a patient in a phase 1 trial.
Well, you're right, Jim. Actually, investigators have struggled with this. Matthew Miller is an oncologist who was supervising phase 1 research at a major cancer center and wrote a little bit about what that experience was like for him. He wrote, "Patients referred to these trials were desperate and grateful for a forum in which they could continue to fight their disease. In reality, of course, it was they who were called on to make a sacrifice and to whom any debt of gratitude was owed." But he said, in enrolling patients in these trials, I was reinforcing the fiction that we were about to embark on a therapeutic enterprise. An opportunity to unpack research from therapy was transformed into an occasion that conflated the two. Now, what Dr. Miller was referring to here is a concept called the therapeutic misconception. This was first realized by psychiatrist Paul Applebaum more than 20 years ago. And it's a very important concept. It refers to the false belief that the purpose of research is to benefit the patient. In fact, the purpose of research is to benefit future patients. But we see this over and over again among patients and investigators alike. And it manifests as when a patient will say something like, "My doctor wouldn't have recommended this study if she didn't think it would be good for me." Now, we know that in the ethics of research, it's important that patients understand what trials are about. And so we need to deal with the therapeutic misconception. We need to remember that the purpose of research is always to gain generalizable knowledge with the goal of helping future patients. Sometimes it's true, patients may benefit from participating in research, but this is never the purpose of a clinical trial. And this is one of the things that makes clinical research fundamentally distinct from clinical care. So again, it's true that sometimes patients may benefit from being involved in a research study, and it depends a lot on the type of the research that's being done. So for example, volunteers in pharmacodynamic studies clearly have zero chance of benefit. Patients who enroll in phase 1 studies, as we've seen, have a small chance of benefit. On the other hand, if you're enrolling in, let's say, a phase 3 trial where there's very promising preliminary results about the drug, well, then your chance of benefit may be significant. But again, given that it's very important that patients make a voluntary choice to enroll in phase 1 trials, they do need to understand, and we need to be assured, that these patients have an accurate understanding of the purpose of the research and the risks and the benefits that are involved.
Okay, that makes sense, but I've heard my colleagues use the phrase therapeutic research. I guess I don't understand it. Isn't research sometimes therapeutic?
You know, Jim, you're right. I mean, this concept of therapeutic research, we hear it a lot, it exists in the literature, but it's fundamentally a mistaken concept. It's really just one more example of the therapeutic misconception. Surprisingly, it's been around for a long time. It's even embedded in some of the older codes of ethics. So the original Declaration of Helsinki differentiated between research that offers therapeutic benefit, which they called therapeutic research, and research that is done for purely scientific objectives. But you know, Jim, if you think about it, the very term therapeutic research is itself internally contradictory. It's what we call an oxymoron. If we knew that what we were doing was therapeutic, then it wouldn't be research at all. It would be clinical care. And so over the decades, people have recognized this fallacy, and newer codes have actually abandoned this distinction.
So you're telling me that phase 1 research might still be ethical even if it is not therapeutically beneficial for the individual patient. What then determines whether a phase 1 trial is ethical?
Well, remember going back to our original 7 concepts, it's important that research have a favorable risk-benefit ratio. But it's important to understand how this differs in research than it does in clinical care. So for example, when we're thinking about clinical care, there's only 2 things that matter: the benefit to the patient and the risk to the patient. And the decision-making is fairly straightforward. We offer something when the benefit outweighs the risk. Well, we think about this in clinical research in a very different way. How do we measure benefit to the subject against risk to the subject? Well, as we've seen in much phase 1 research, the benefit to the subject is small, but the risk to the subject may be large. Now, if this were clinical care, we wouldn't do it. So how does it become ethical in the context of research? And the way that it does is because in research we're allowed to add in the benefit to society onto this scale. Now, first of all, notice that this is very difficult to do. These things cannot be weighed against each other in any sort of objective way. I mean, for example, how would we ask how much societal benefit do we need to compensate for, let's say, a 10% risk of mortality for the subject? There's no clear and straightforward way to do that. And this is one of the reasons why we have to get ethics committees involved to think about this, that this should never be a balancing that's done by the investigator alone. And so in the United States, for example, we have ethics committees called institutional review boards that do this balancing. The other thing you may ask is, well, you know, how could this ever be ethical in terms of the subject if the benefits to the subject don't outweigh the risk to the subject? And here again, this is one of the ways that consent for research is so much different than consent for clinical care. Patients or subjects need to understand what's going on here and need to give their voluntary consent in order for this to be ethical.
Well, that's very interesting. I can understand now why phase 1 research is ethical from a societal perspective, but I still don't understand why a patient would choose to participate in a phase 1 trial.
Well, that's right, Jim. A lot of people have a hard time understanding how somebody who's fully informed about what's really involved in phase 1 research would ever agree to become a part of a trial. I think it's quite reasonable to ask, is it irrational for patients to choose such high risks for such a small chance of benefit? And I like this cartoon from the New Yorker. I mean, I think it sort of illustrates the dilemma here. We have the investigator there with a treatment that looks to be very painful and unpleasant, offering it to a potential research subject and saying, well, you know, this may buy you 4 weeks. Why would anyone ever agree to enroll in this kind of an agreement? But it turns out that there are actually some reasons why patients may want to enroll in phase 1 trials. First is altruism. Studies show that subjects really do want to help future patients, especially those who share their medical condition or their disease. Nevertheless, it's important to note that altruism is almost never the sole reason why somebody would enroll in a phase 1 trial, and rarely is it the most important reason. Instead, studies show that the most common reason that patients will enroll in phase 1 trials is the hope for personal benefit. But you know, if you think about it, these are patients who are eligible for a phase 1 trial because they have exhausted all potential therapeutic options. If they really do want any therapeutic benefit, this is truly their only realistic hope. Typically, the main alternative to enrolling in a phase 1 trial is palliative care, where the patient is going to trade off a small chance of personal benefit, therapeutic benefit, in order to maximize the comfort of their care and the quality of their remaining life. Now, many people have been critical that at large cancer centers, clinicians do not adequately present palliative care as a reasonable option. And I think it is very important that we do that. I think that patients that are considering enrolling in phase 1 trials must be informed about the option of palliative care, and preferably by an expert in the field. And indeed, when patients in this position do fully understand the small benefits of enrolling in a phase 1 trial, versus the benefits of quality of life of going with palliative care, many of them will opt for palliative care. But on the other hand, we do know that there are many patients who value continuing the struggle against their disease, even when the odds aren't very good. And this is very much a personal choice. I think that perhaps this option is best represented in the famous words of Dylan Thomas: "Do not go gentle into that good night. Rage, rage against the dying of the light." A person who actually enrolled in a phase 1 trial put it very well in the following quotation: "Letting a person choose the poisons adds something to the will to struggle. This is how I wanted to die, not in a suicide and not passively accepting, but eagerly in the struggle." So this really explains, I think, the motivation of patients who truly can opt for phase 1 research, fully understanding what's involved. So Jim, let me summarize here sort of, I think, 2 main points that I'd like for everyone to take away from this module. That first of all, the low chance of benefit makes phase 1 trials highly conducive to the therapeutic misconception, to the false belief that the purpose of this research is to benefit the patient personally. Patients need to have a realistic understanding of the goals of the research, the chance of the benefits, and the risk of harms. But if they do understand these and they voluntarily consent to them, I do think that it's reasonable to say that the overall risk-benefit ratio may nevertheless be favorable. Why? Because in the way that we talked about, the risks to the subject are balanced not only against personal benefit, but also against the knowledge to be gained. And because for a subgroup of patients, choosing a phase 1 trial over palliative care is a personal choice that can make sense and be desired by a certain number of patients. Thanks very much, Jim.
Thank you, Bob. We really appreciate this explanation of the ethics of phase 1 trials. We'll now turn to the next subject of this course, the design and evaluation of phase 2 and phase 3 clinical trials.